Thank you, and good afternoon. I act for clinically vulnerable families, together with Hayley Douglas, Lamisa Iqbal, and we are instructed by Kim Harrison and Shane Smith of Slater and Gordon. I start by thanking the Chair, counsel to the inquiry, solicitors to the inquiry, and all of the excellent building staff for their dedication and collaborative way that this module has proceeded. In my opening, I identified 3 principles. Schools must be safe, and where they're not safe enough, children must be given appropriate support to continue their education at home. And finally, that we cannot offer safety and support unless we recognise the impact COVID-19 has had and continues to have on clinically vulnerable children and families. They need status as a distinct group. So, safety, support, and status. After 4 weeks of hearings, there's ample evidence for the inquiry to make strong findings in all 3 respects. I'll start with safety. Making schools safe is the only way to solve, or at least reduce, the dilemma of whether to send children to school during a pandemic. This is not just a dilemma for authorities. There is good evidence that many schools can be made safer for clinically vulnerable children and those in clinically vulnerable families. In fact, for all children. It's very important not to fall into a false dichotomy. Susan Ackland-Hood, the former Department of Education Permanent Secretary, said, taking decisions about school closures in a pandemic, there are some things where the impact is so great it genuinely should be weighed up against the risk of mass fatality. But it's possible to focus on the bigger picture and still be flexible and compassionate enough to ensure that clinically vulnerable families are not left behind. And improving school safety is one of the only ways to reduce the sharpness of that dilemma in future. Because if a school is safer, then sending children to the school will do less damage to the R rate. How can we make schools safer? There's plenty of evidence now before the inquiry. Professor Catherine Noakes said the evidence base is all pointing in the same direction, that better ventilated environments provide a healthier environment for children and adults. They help you mitigate against disease. They help you mitigate against other respiratory conditions. If those environments are designed well and they're thermally comfortable, they create better quality learning environments. Sir Chris Whitty said, it's an uncontroversial statement from an epidemiological point of view that improving ventilation in schools would be a good thing. It would not just be for future pandemics of a respiratory sort like this one, but also for year-on-year flu and other respiratory infections which cause a lot of trouble in schools and lead individuals to not have their schooling. The second point is that ventilation works not just for clinically vulnerable children, but for everyone. Professor Noakes said, improving ventilation is not just about reducing COVID transmission, it's also about improving those environments for other respiratory infections, improving them for children who might have asthma, improving them in terms of the cognitive performance of children in schools, and for the learning environment. Sir Hamid Patel suggested linking CO2 data with learning outcomes. Because if ventilation, good ventilation, is important for health, we can establish that good ventilation is important for learning, for concentration. Then that means schools that don't have good ventilation, they have poorer ventilation, their kids are disadvantaged even before they step into an exam hall. Despite all this evidence, there is a reluctance to recognise that clean air and ventilation in schools is important. And there's a strange disconnect between the high level of proof which some people require to show that measures like these work, compared to the low level of proof which was used to justify the enormously disruptive school attendance restrictions between 2020 and 2021. Dr. Shona Arora of the UK HSA was asked which protective measures in schools actually worked, and she said, "We probably don't know with huge certainty." And I don't quite make the same point that Mr. Friedman made about that being a justification for fewer restrictions. But I do say there is a strange disconnect in terms of what we expect from our data. There's often talk of waiting for the gold standard of evidence, that is, randomised controlled trials, to show that ventilation and air cleaners work, but that's never going to come. And that attitude was apparent in Module 3 too. It's simply the wrong approach. There'll never be that evidence in dynamic environments with many confounding factors. There is sufficient evidence and consensus now for the inquiry to recommend that clean air is prioritised in schools, and that work is done to change the culture of schools to ensure this happens. Clean air is just as important as healthy school lunches and safe playground equipment. Clean air needs an evangelist like Jamie Oliver was for good school lunches. Chair, we ask you to be that evangelist. This could end up being the most important thing the inquiry recommends for public health. Second point is on support. Sir Hamid Patel said that families often faced a moral and emotional dilemma. Do you protect your loved ones? Do you comply with attendance rules? And it also places schools in a policy vacuum, expected to enforce attendance while managing real trauma. Mark Drayford said yesterday that if you talk to children at the time, they did not have a view that somehow their rights were being subjugated to the rights of other people. They talked to you all the time about their fear for their grandparents, a fear for their father who worked away, their fear for their sister who had an underlying health condition. This was, and for some, remains a genuine dilemma. There's been too much talk about fear and anxiety, as if worrying that COVID might kill you or your vulnerable relative is some kind of pathology, a mental health problem rather than an unaddressed risk to physical health. And this is why flexibility towards clinically vulnerable families is so important. How can it work in practice? Lara Wong, CVF's director, said this: flexibility could mean a number of different things. It might mean learning remotely, and it might mean hybrid learning. And by hybrid learning, I mean in class, to an extent, but maybe in an outdoor classroom. They have things like forest schools for younger children. There are many creative solutions. Sir Hamid Patel gave an important insight into what happened in the schools that he ran. He said some parents didn't feel reassured, so we took a risk assessment. We offered them online lessons. We carried on doing home visits because those were intergenerational households and many parents were clinically vulnerable. This local flexibility was in contrast to the overly punitive policy which many clinically vulnerable families reported was in place in England. Families who had entirely legitimate concerns were encouraged to off-roll their children or fined or prosecuted. Gillian McCluskey, the inquiry's education expert, said it felt as though England, in this particular point, was emphasising a strict and punitive approach, whereas the other three nations weren't. They were talking about the need for understanding, support and flexibility. Boris Johnson emphasised the importance of momentum when children were returning to schools in September 2020. But the reality was that in the rush to get all children back to schools, clinically vulnerable families' legitimate concerns were minimised, and this was the wrong approach. My final point is about status. To properly understand how clinically vulnerable people were and continue to be affected in the education system, they must have status as a distinct group, so that they're included in decision-making, data collection, public reporting and funded research. Recognition should include making clinical vulnerability a protected characteristic in the Equality Act. There's a yawning gap in the data, and it needs to be filled. Professor Catherine Davis, the inquiry's early years expert, said, "We haven't really mentioned the clinically extremely vulnerable children, whether themselves or members of their family. Those children will have experienced much longer isolation, higher anxiety, and a lack of specific guidance. I would really welcome and encourage more data tracking, more advocacy for those groups, and what is quite a specific set of circumstances during the pandemic." We ask that this is a recommendation in this module, but we will also be making submissions at the Module 10 preliminary hearing about how the inquiry can itself start to plug some of the gaps. In conclusion, there are no easy answers to the issues identified in this module. It can seem sometimes that there are less answers and more dilemmas. A number of witnesses said that in the end, they were left choosing between one bad decision that was just a bit less bad than another bad decision. But if you focus on safety, support, and status, that would go a long way to protecting clinically vulnerable families now and in the future.